Hi, everyone. It's a pleasure to introduce this year's first webinar sponsored by the Frank J. Veith International Society. As some of you may know, this society was created 4 years ago by all 33 fellows trained by Frank Veith. While recognizing his multiple achievements to vascular surgery, this society is engaged in doing the one thing that most pleases Frank, that is, to develop high-level educational conferences and webinars, as well as international forums to stimulate the creativity of young and upcoming surgeons. I promise to be short and not take precious time away from this very interesting webinar. Yet, I'll be remiss if I didn't mention how happy we are to have Dr. Peter Klovitsky as our third president, following the legendary Dr. Juan Parodi. Peter is currently the Joe and M. and Ruth Roberts Emeritus Professor of Surgery at Mayo Clinic College of Medicine. He is also a consultant and Chair Emeritus Division of Vascular and Endovascular Surgery at Gonda Vascular Center at Mayo Clinic, Scottsdale, Arizona. Thank you, Peter, for organizing this superb webinar. By the way, Dr. Klovitsky's biography was recently published in a beautiful book entitled Magic and Medicine, The Extraordinary Journey of a Vascular Surgeon. I read it and I highly recommend it to you. We are equally happy to have with us today Dr. Alessandra Puggioni to moderate the webinar with Peter. Alessandra is a superstar in the management of venous diseases.
All right, sounds like you're all good.
Anil Hingarani and I were lucky to have had Alessandra join our practice a few years ago before she went back to Italy. She deserves all the credit for starting our busy iliac vein stenting program. Great to have her back in New York as the Director of Clinical Affairs at Metro Veins Centers. Alessandra is also the Director of American Venous Forum Foundation. Last but not least, I would like to sincerely thank our speakers and discussants for taking the time from their busy schedules to share with us their clinical experiences with iliac vein stenting. Without further delays, I'll pass the mic to Dr. Peter Klovitsky. Peter?
Good morning, everyone. Thank you, Dr. Escher, for your kind introduction. It has been an absolute privilege for me to serve as president of this international society this year, a society that honors Dr. Frank Veith. Now, today's webinar deals with a hot topic in venous disease because stenting has revolutionized the way we treat patients with iliofemoral venous obstruction. There is increased awareness of the disease. Diagnosis has improved with duplex scanning and intravascular ultrasound, and the FDA approved several dedicated stents. We are fortunate to have an outstanding group of international experts here today to tell us how to select the right patient, what is the best technique, which stent should we use, and how to assure long-term clinical success. Now, each presentation will be followed by an expert discussant who will, to start with, just ask one burning question to our presenter. So it's a pleasure now to introduce my co-moderator, Dr. Alessandra Puggioni. Alessandra.
Thank you. I'm very humbled by your introductions. And thank you all for inviting me to co-moderate this international summit. It's truly a pleasure and an honor to be here today at this very well-attended event with the great speakers and panelists. And I would like to start by getting into our first presentation. The speaker will be Dr. Eddie Murphy, who is the Director of Venous Lymphatic Institute at Sanger Heart and Vascular in Charlotte, North Carolina. The title of our presentation is The Venous Stenting Landscape. Welcome, Dr. Murphy.
Thank you. So yeah, as we just said, we're going to talk about the venous stenting landscape. And I think it's important when you think about landscape to start with, you often think of the technology we have available. But the landscape is a bit broader than that. So we're gonna touch through the rest of it as well. There's some good, there's some bad, and there's some ugly, and we'll set the stage for the rest of my colleagues to provide some education through this. These are my disclosures. The venous stent landscape 5 years ago in the US, we all had these disclaimers on our disclosure slide. All IVC and iliac vein stenting is currently off-label. We've certainly made some progress since then. We've been through various phases of 5 FDA trials in the United States. We now have several stents that are available to use. Most of the newer stents are nitinol. We've made so much progress, we've actually seen some of these stents already come and go. The Vici has officially been pulled off market. The Venovo stent is expected to come back shortly, but is currently unavailable. The wall stent has progressed to a venous indication, and then the Vesper stent is currently still finishing up its trial and is not available for commercialization yet in the United States. Anticipated within the next couple of years. So while we currently only have 3 players, we are expected to have more, and I'm sure the progress has not yet halted on the technology side. Having these solutions available gives us, and these products gives us a variety of solutions. Wall stents have tried and true data. They are flexible. They have braiding, which prevents fracture across the ligament. We kind of know what we're getting with these, but they also have their downsides. The nitinol stents have some more predictability, precise delivery performance. This is important when trying to land things in exactly the place that you want them. Durability testing has yet to be seen, but with some of these stents has been tested out to 50 years. The stents are available in longer lengths and have certain advantages for the venous system as they were designed solely for that. Over time, these stents may differentiate themselves to various roles and may serve better in one place than, or in one role than another. The ID trials have shown us that we have good 1 to 3 year patency for NIVL patients with all stents. We've shown that the stent patency for PTS may be lower, but it's still reasonable. But also we've seen that there's room for improvement in this group across the board. All ID trials importantly demonstrate that there's an improvement in quality of life and functional assessment scores after stenting if done correctly in the right patients. Importantly, there are huge advantages simply to having a stent on label. Having this allows us to have not only more data, but it has normalized venous stenting to the point where it's gone from kind of in the shadows to widely available and used for better or worse. The amount of stenting done in the United States for sure has increased dramatically. A plus is that the availability has allowed for funding for research and education through industry. And regardless of how you feel about industry involvement in things, nobody can deny that right now, the primary way that people are learning how to do these cases is through post-fellowship education. And that requires funding and support. Multiple stents on the market does drive competition between them. So we do see a big push for knowledge, a push for research, a push for improvement in products and further development, which also helps us to push our field forward. Not everything in the landscape, though, is great. Part of this is that this technology focus of our landscape has well exceeded the knowledge base. So we now have a lot of people with something in our hands that we're still trying to figure out how to use in many cases. And no specialty has yet embrace the importance and complexity of venous disease. No specialty is spending the amount of time on venous disease as they are on PAD or aortic or carotid. And those fields we know a lot about already. Venous is we're still developing this. The field, unfortunately, is underestimated. It's misperceived as easy. The failures are misunderstood. So instead of looking at them to gain improvement, we're often looking at, I'm hearing things like, oh, the patient didn't get better, those crazy vein patients. The stents failed, but if you operate on a vein, that's what happens. It's patient disease. The patients are misperceived as doing well because they're not followed. So an initial short-term success is then perceived to be a long-term success, which is not always the case. Technology without knowledge and without an understanding of where our gaps are, and currently combined with arterial expertise, which leads us to this false sense of security, is leading to stent complications. And I think my colleagues will talk a bit about that. just as a brief overview, some of the things we're seeing most commonly is failure to improve. Often this is resulting from poor patient selection, patients who don't need a stent occlusions, again, some selection issues, some under-stenting, patients who still have remaining inflow disease, technical errors, access errors, anticoagulation errors. We're seeing stent migration. I know this has been probably the most talked about complication, even though it's probably not the most common. But where we typically see this is a patient, like this. This stent moved, but when I inquired as to, what the iliacs look like, I was told, oh, they're quite large. And when you look, this patient didn't really have a Veith ulnar that was stented. And this stent wound up, in the abdomen and having to undergo eventually an open removal. Sizing issues, selection issues, stent malalignment, landing on a curve, stents not lined up correctly. We're starting to see all sorts of issues. So the landscape is not just our technology, but it's also our selection, our techniques, our outcomes. And the current landscape is one not just of overtreatment and mistreatment, which we've been talking about for a while. It's also an undertreatment in an under-recognized population in a space that's under-evidenced. So I think we have a bit of way to go with education, research, looking at our failures, and driving forward for positive field development. Thank you.
Thank you. Thank you, Dr. Murphy. Certainly those procedures should be left to those who have a specific interest in venous disease. It was an outstanding presentation. It is my pleasure now to announce again the first discussant who needs a very little introduction. Dr. Glovitsky, among other achievements, is a true pioneer of venous surgery, a mentor to me, and has trained and inspired countless vascular surgeons. Now I would like to handle the virtual microphone to Dr. Glovitsky.
Thank you very much, Alessandra. Dr. Veith is going to have his burning question a little bit later to Erin. I hope that he will be able to join us. Erin, this was an excellent presentation. Obviously, the issue is very complex. As far as the stents are concerned, I have a question specifically. Do we know if one stent is better than another? Is nitinol the right material? And is an open cell better than a closed cell for venous disease?
Yeah, so I think the stents are differentiating, or may over time, and certainly I think more so as we get into the next generation of stents. These were all our kind of initial stents coming out, but I think the stents that there are certain ones that are differentiating their ability to cross the ligament without fracture. I think the nitinol stents are proving to be easier to nail the confluences if you need to land something exactly at the profunda femoral junction. I think overall the open cell stents have been better for flexibility. At the top, I think some of these stents may a closed cell stent was probably doing a little bit better under the artery, but I don't think some of these open ones are doing too badly either. So I think time will tell which stents to use where and where to go next, but I think they are starting to have a preference depending on what you need to do.
Thank you very much. You already brought up the issue of appropriate use of venous stents, and Dr. Arjun Jayaraj is going to continue this discussion with his presentation, Patient Selection and Best Technique for Iliofemoral Venous Stenting. Dr. Jayaraj is representing Dr. Raju's group, and he works at the Rain Center for Venous and Lymphatic Disease in Jackson, Mississippi. Dr. Jayaraj.
Thank you, Dr. Glovitsky, for the kind introduction. It's a great honor to be part of this eminently qualified panel for the webinar. So thank you very much. I have no financial disclosures relevant to this talk. The purpose of venous stenting is fundamentally different from that of arterial in the sense that the goal of venous stenting is to reduce peripheral venous hypertension and not so much as to restore patency or promote perfusion, as is the case with arterial stenting. Let's consider the scenario of a 55-year-old lady who presented with disabling pain, heaviness, tiredness, and swelling of the left lower extremity, in addition to skin changes. Initial workup included a duplex ultrasound that revealed stenosis across the common femoral, external iliac, as well as the common iliac segments. Cross-sectional imaging in the form of a CT scan confirmed the findings of stenosis across the entire iliofemoral segment. At this point, this lady had already failed conservative therapy, including using compression stockings, as a result of which it was decided to proceed with IVUS interrogation of her iliofemoral segment on the left side with intent to treat. Ultrasound-guided access was obtained in the mid-thigh femoral vein, followed by placement of 11 French access sheath. An ascending venogram was initially performed in order to delineate the flow dynamics, and you'll notice the long segment stenosis here. IVUS interrogation revealed a common femoral vein luminal area of 109 millimeters squared, an external iliac of 116, and a common iliac vein of 117 millimeters squared. A few words about venous stenosis. It's important to bear in mind that in venous stenosis, there is a continuous rise in venous pressure with stenosis without a critical stenosis point that one encounters in arterial stenosis. Additionally, comparison to an adjacent normal segment or a contralateral segment is problematic because of the presence of skip lesions, long segment stenosis, as well as bilateral disease. One can overcome this problem through the use of IVUS determined normal minimal luminal areas, and we use 125 millimeters squared for the common femoral vein, 150 millimeters squared for the external iliac, and 200 millimeters squared for the common iliac. Any luminal area below these cutoffs in a patient with quality of life impairing symptoms not responding to conservative treatment merits stenting in our view. In preparation for stenting, predilation is carried out, and in this particular patient, we used an 1860 angioplasty balloon, and you'll notice the distortion of the contours of the balloon with angioplasty. Now, with regards to stents, as Dr. Murphy mentioned, a variety of stents are available across the globe, and currently, these are the ones, the highlighted ones, are what are available in the United States. A few words about stenting. It's important to exclude all areas of disease so that there isn't residual venous hypertension left behind. It is okay to stent across the inguinal ligament in order to ensure adequate inflow and to go as high cranially as necessary to ensure that there is good outflow as well. As far as stent sizing goes, we use the inflow channel IVUS luminal area to guide our stenting, and this determines the size of the caudal stent, and we upsize about 2 millimeters for the cranial stent. And this applies just to wall stents. Depending on the physical properties of the stent being used, the sizing will need to be adjusted accordingly. Post-dilation is typically carried out with the previously used balloon, and IVUS interrogation is performed to ensure adequacy of luminal areas. So this is what we started out with, and this is our final veno. And in this particular patient, we used a composite stent configuration of wall and Z stents. And we ended up with a common femoral vein luminal area of 176 millimeters squared, external iliac of 188, and a common iliac vein of 201 millimeters squared above the luminal areas that I previously mentioned. As far as antithrombotic therapy goes, we use a combination of prophylactic enoxaparin and bivalirudin preoperatively in our practice. Postoperatively, anticoagulation is continued in patients who are already on this pre-procedure, and it started on patients who have thrombophilia based on intraoperative findings, or those who have early severe in-stent restenosis on duplex ultrasound. As far as post-procedure follow-up goes, we obtain a duplex on the day of the procedure. An overwhelming majority of our patients go home the same day. So this is our baseline post-procedure scan. And a follow-up duplex exam with a concomitant clinic visit is done at 3 weeks, 3 months, 6 months, and then yearly as long as the patient is clinically doing well with a patent stent. Now, with regards to patients presenting with bilateral lower extremity symptoms, we looked at this a few years ago. In 368 limbs that underwent unilateral stenting, we found that over a median follow-up of 20 months, only 5% of limbs required contralateral stenting, either as a result of lack of improvement or progression following initial improvement. And this supports a staged approach to stenting in patients with bilateral symptoms. So in essence, the goal of stenting, venous stenting, is to restore normal minimal luminal areas and thereby relieve venous hypertension. However, it is essential to confirm diagnosis and assess adequacy of stenting. It's important to individualize stenting to the patient. Antithrombotic therapy can be selective, and long-term post-procedure follow-up is key. Thank you.
Thank you very much, Dr. Jayaraj. I'm sure that you are going to have a lot of questions during our panel discussion. We have a burning question coming from the Netherlands by Professor Kees Wittens. He's Professor of Venous Surgery and Secretary of the European College of Phlebology from The Hague, the Netherlands. Dr. Wittens, go ahead with your burning question.
My burning question, thank you, Peter, and all panelists for having me in. And I'm really happy that he showed this case, because this case, the first phlebography he showed without any collaterals, we wouldn't do anything and bail out. And I think that indications for stenting are critical. And my question is, because we know that stents do, although they are patent, that there's no improvement of patient clinics, why don't we do an invasive measurement in the groin, do a pressure measurement, and if the pressure doesn't go up on a treadmill, don't stent those patients? And that would take out the indications, I think, at least for 30–40% of the patients who now get an iliac stent. So my question is, why don't you do an invasive pressure measurement to select your patients and accept high incidence of patients having a stent that doesn't help their clinical situation?
Thank you for the question, Dr. Wittens. Hemodynamic monitoring is helpful, but again, it is fraught with problems, including measurement error and the like. And again, the extent of pressure gradient from the ankle to the right atrium is only about 11 millimeters. And across a 4-inch segment from the groin to the inferior vena cava, it's less than about 3 millimeters. Well, in most patients, it's about 1 to 2 millimeters. So the thing about venous stenosis is that a small amount of stenosis can elevate the pressures, but not to the point where they can be discerned by measuring venous pressure, either at the femoral level or at the level of at the dorsum of the foot. So unlike arterial, the pressure gradient in venous disease is so mild, and that a gradient is hard to discern in most patients. Now, you do have patients in which the gradient can be significant, especially those in patients who have occlusion of the common iliac or the external iliac. But otherwise, in most patients, especially in this patient, you really don't find a significant elevation of venous pressure, either in the groin or in the dorsal foot vein. Now, as far as collaterals go, our experience has been that we see collaterals in about 30% of patients who have significant iliofemoral venous stenosis. And so using collaterals as a definitive guide to sort of guide stenting, at least in my personal view, I think is inadequate.
Am I allowed to respond, Peter, or is it just?
You are not allowed to respond right now, but I hope that you will be able to respond at the end. So hold your questions, and Alessandra is going to introduce the next speaker.
Yeah, thank you very much for the very interesting presentation discussions. Our next speaker is Dr. Stephen Black, who is a reader at the King's College and a consultant vascular surgeon at Guy's and St. Thomas Hospital in London, UK. He will be presenting tips and tricks for safe and durable vein stenting. Welcome, Dr. Black.
Thank you very much, Alessandra, for the kind introduction, of course, to Peter and the Veith organization for hosting this, and Enrico for the wonderful introduction at the beginning. It's a great pleasure to be here. So these are my disclosures, of course. When you are stenting, what do you need to think about? And these are the things that are going to keep you safe and stop complications from happening. Technical issues, of course, the thing that we can control. That's which stent you choose, where you put it, not making mistakes in deployment, and using things like IVUS to minimize potential errors. The other factors to think about are obviously patient factors like clotting and what you're going to do about anticoagulation, and physical factors like inflow and the vessels below the area that you're going to stent and above the area that you're going to stent, to make sure that that they are suitable for a patient. And actually, when you look at all the data and the analysis of what goes wrong in venous stenting, most errors are of a technical nature. And I would suggest that most technical errors are not the fault of the product, but the fault of the user. And we have a tendency as physicians to blame the product before blaming ourselves for errors. And Erin has alluded to that in her talk already. And I think that's an important factor to think about when you want to minimize risk to your patient. Mistakes happen in multiple places. They happen principally in patient selection. If you don't treat patients inappropriately, you can't make mistakes on that patient that cost them their life in the worst case scenario, or cause complications that didn't have to happen if the patient didn't need an operation in the first place. So the really principal thing about avoiding errors and keeping venous stenting safe is not to treat people who don't need disease. Then you can have errors once you start treating at any stage of the procedure, be that access, where you can cause fistulas or bleeding, crossing with damage to surrounding structures, the stenting process itself, and the follow-up if you get things wrong. In terms of getting things wrong, it's almost never one big thing. The rarity of catastrophic complications in venous stenting probably breeds complacency because, again, Erin alluded to this very well in her talk, that the patients get blamed for the outcome, or you don't notice the dead leg or the ruptured aneurysm as we do in arterial surgery that brings to mind an obvious complication. The biggest possible disaster you can have in venous stenting, of course, is stent migration, which is the one thing that can lead to instantaneous death. But there are other issues that can happen in terms of pulmonary embolism and so forth, which we need to avoid. The main lesson for me after going through all of this is that it's important to make novel mistakes. There are plenty of things that everybody on this panel has done wrong. I've made a number of errors in treating patients over the years, and all of us have shared them. And you will find talks and information on the web when you talk to people that allow you to learn from others' mistakes so you don't make them yourself. If you're going to go out and do something, make new mistakes and come and share them with the rest of us. So how do you stop all of this happening? The first thing you need to do is spend time learning. I think that actually Case Fittens is on this talk, but when I started out in venous the disease, I spent probably a good session sat in Case's European venous course at that time, and then of course at Veith sitting through the venous sessions to just immerse myself in venous disease before I treated a venous patient. And over the years that I've built my practice, I've spent a lot of time talking to people who've done it and learning from them. Peter Neglin was instrumental in my early experience. Paul Gagne is on this talk, Jerry O'Sullivan, Kush Desai, Erin Murphy, Nick Kostopoulos. There's a number of people, Bill Marston, who really know what they're doing. And we share a lot of our clinical practice and share a lot of our problems. So we learn from each other all the time. And you're never too experienced to share your problems and learn from other people. And you're never too experienced to be challenged by a difficult case. And when you come across things you're not sure about, rather than plowing on, learn about it and make sure you understand the problems before you experience them. The second component to mitigating error is building a proper team. In my hospital, I'm very privileged to have a number of wonderful people who are part of the team that I have, which are hematologists, nurses, interventional radiologists, ultrasound scan technicians, and other vascular colleagues to treat venous disease. And it means you create an environment in which the patient is central, and you can consider multiple different aspects of the patient before you treat them, such that you don't walk into somebody who has, for example, triple gene positive antiphospholipid syndrome without a clear plan for anticoagulation, which stops you from making mistakes. Technical issues that you might encounter that we've all found are things in crossing, for example. Are you in the right place? You can see this patient here where you have a venogram that looks all right, but actually the stents are in the azygous vein. Now, what that involves is having
the text that you're now on.
it ended up in the wrong position. Sorry, there was a background talking there. Apologies for pausing. You end up in the wrong position in the vein and put the stents in the wrong place. It's very clear. We learned this from Rick de Graaf, who gave lots of instruction on this from his early experience from Maastricht with Case Fittens, that you need to do lots of AP and lateral views to make sure that your wires are where you want them to be, particularly when you've got difficult chronic occlusions to cross. The second point about technical errors that we learned from venous disease was you need to do things like proper pre-dilation. If you try and post-dilate stents, like we see in these two pictures, after you've done the crossing, the stents will never open properly. So all those technical things that are not typical of arterial disease that you need to apply to venous disease have to be learned and have to be done. The biggest catastrophe you can have is migration. And that has been very prominent for us in the last year with the withdrawal of the Veith stent from the market, secondary to migration. And it's arguable for me, and still my very firm opinion, that the stent was fine. The complication did not come from the stent. The complication came from how it was used. And it's very important to concentrate on that. In my practice, I make sure that I don't size stents for the pre-dilated segment of vein. In fact, I would say that my practice contrasts to that of the previous presenter in that I would never consider using stents of 20, 22, or 24 in the common iliac vein, because I think we run into problems, particularly in the new era of nitinol stents. Make sure your stent is sized for a good segment of vein. Take the stent around the bend in the pelvis so that it's landed properly, and ensure that you've got adequate wall apposition throughout, and you'll find your stents don't migrate. We've recently, together with Kush Desai and Jerry Sullivan, published a review of stent migration in the Journal of Vascular Surgery, Venous and Lymphatic. And this demonstrably showed that a small, undersized stents are much more likely to migrate than anything that is appropriate sizing. 97% of all stent migrations involve stents smaller than 14 millimeters in diameter and less than 60 millimeters in length. So it's very important to avoid those sizing errors. Coming around the bend is analogous to what we learned in arterial disease. Professor Veith and others were pioneers in this, showing that if you landed limbs of aneurysm repair on the bends in the pelvis, you had problems with those limbs. And I think the same thing applies to venous disease. You want to take the stent out the bend in the pelvis so it's embedded in a good segment of external iliac vein, so you don't run into problems with tenting and straightening. And these are a few of the things that you can get with big oversized stents or tenting and straightening. You can see this oversized stent in the iliac vein, which is 20 millimeters and straightened on the bend, is cut out through the common iliac vein and has become occluded as the vessel disrupts the vein. You can see here again, there's another stent here that is cut out through the common iliac vein because it is oversized. This is an image that I got from Erin, of course. And in this particular case, the stent which wasn't taken around the bend has straightened on the bend in the pelvis, and you get tenting and straightening around this curvature, leading to reocclusion of the stent over time. So getting these things right is really important. This is another one. You can see a very straight stent pointing down into the pelvis, and the angle with the external iliac vein is completely wrong, and you end up with problems. What we also have to remember is that the bailout with open surgery, if venous stenting is done wrong, is not great. When we do peripheral arterial disease, if you do an SFA stent, angioplasty and stent, and it doesn't work, everybody is comfortable doing a FEMPOP bypass or open arterial bypass surgery. Venous disease is not the same. So the impetus for us to get things right the first time has got to be higher. We've got to consider the consequences if you put in stents badly, as this patient illustrates. Having to do a crossover bypass graft in these sort of patients is not fun for anyone, and there's very few people who enjoy taking on open venous bypass surgery, apart from probably Peter Glavitsky, has made such a career out of those sort of operations. So the lessons learned in keeping out of trouble, primarily, and I'd highlight this, is only treat patients who need treating. If you don't go down the road in the first place, you can't cause problems. And I think there was a great quote which comes from a book called The House of God by Samuel Shem, which I've always remembered through my training. The art of medicine is do as much nothing as possible. As soon as you get into trouble with medicine, it's because you've done more nothing than you should have. Bad stenting leads to difficult problems, and our open bailout options are not easy. Most problems are avoidable and down to the clinicians. So it's really in your hands to control this and make sure you do it right. And that involves obsessing about the details, having buddies, and being humble. I think we've got a plague of social media overload of trying to find great pictures to put on LinkedIn and Twitter to show how wonderful we are instead of focusing on the patients, and we're losing track of that. So the bottom line is keep the patient first and foremost, and you'll probably keep yourself out of trouble. Thank you very much.
Thank you, Dr. Black, for the great presentation. Dr. Paul Gagne will be the distinguished discussant for this talk. Dr. Gagne is a clinical associate professor of surgery at the NYU School of Medicine and a partner at Norwalk Hospital in Dayton, Connecticut. Dr. Gagne, you may ask your burning question now.
Thank you, Alessandra and Stephen. Very nice presentation. Stephen, you kind of highlighted a lot of the ways we can all get in trouble, and the more stenting we do and the more tools we have to work with, we will find new ways to get into trouble. We're also generating more and more data as further IDE trials come down the road and further prospective studies come down the road. Have we reached a point now where we can't just assume that a trained vascular interventionalist or surgeon has expertise in venous disease, but they need to either show from their training that they've gained the appropriate expertise to work in this field, or should there be a different certificate? Because it seems like the knowledge and experience is expanding at a rate that people aren't going to learn this going to just a single course or a series of weekend courses.
Paul, I think that's a great question, and I think it's something that, funny enough, I debated Alan Davies on this exact topic at the Vascular Society in the UK, is that undoubtedly, as knowledge grows in any field, we find we specialize more and more. It wasn't that long ago that we were all general surgeons doing hernia repairs, and God help a patient if I had to do a hernia repair on them now, and I'm trained as a general surgeon. So as your expertise changes, it's important to recognize that you need to focus on more and more of the detail to get things right. So I think, to me, that's probably somewhat inevitable. We need to do this, but I think we also need to learn from arterial disease, in that when we were rolling out aneurysm surgery, I remember quite distinctly that before I did EVARs, I had to be trained on the device. I had to be accredited by the company before they'd give me the device to use. And I had to do 10 cases with some significant proctoring to be allowed to do it. To Erin's point, we seem to have this attitude towards venous disease that, oh, it's easy, don't worry about it, you can just crack on. If you can put in a wire, you can do a venous stent. It's just not true. And I think that the kind of mistakes we've seen in patient selection, technical error, and judgment are because people don't have that significant grounding in treating these patients. And we need to be a little bit more aware of that, just because you can hold a wire in your hand and puncture a vessel doesn't mean you have the technical and knowledge base to treat the patient. So I think we owe it to ourselves as a community, and we owe it to our patients to be a little bit more rigorous in that regard. And what that looks like in the future is difficult, because it's hard to accredit things, and it's hard to hold people to account, but I think it's important.
Thank you very much, Dr. Black. We are going to continue this great summit, and the next speaker is Alan Dillawoo. Alan is chief of the Division of Vascular Surgery at WakeMed Hospital System in Raleigh, North Carolina. And Alan is going to talk to us about the need for adjuvant therapy for venous stenting. Alan?
You're muted, Alan. Thank you, sorry. Thank you so much for inviting me, Dr. Asher, Dr. Veith, Dr. Ignorani, and I am so pleased to be part of this distinguished group. I'm going to go ahead and screen share. All right. So I'm going to talk about adjuvant therapy after venous stenting. Here are my disclosures. So as we've heard, deep venous stenting has been practiced for many years, and we have an ever-increasing toolbox with which to do this. But I think there are still some very real questions about antiplatelet and anticoagulation therapy to follow venous stenting, and we've touched on these in a couple of the previous talks. So where to start? As we have discussed, there is a lot of stenting going on, but there are no real guidelines and no large studies to address how to handle antiplatelet and anticoagulation post-stent. Most of the meta-analyses that have looked at this question have been pre-DOACs, and most practices arise from arterial experience. So that sort of leaves us in a conundrum, wondering what the best thing to do is. If you look at the data, the largest meta-analysis looking specifically at anticoagulation after stenting for nival iliac vein compression found that there was a great deal of data inconsistency in the 5 out of 61 or 5 studies that they were able to use, which amounted to only 61 patients. When they looked at 6 months of warfarin only, they had a 78% patency at 1 year, more than 6 months, or 6 months of warfarin plus a direct antiplatelet therapy. I'm sorry, with directed antiplatelet therapy gave them an 89% patency, and lifelong anticoagulation gave them an 81% patency. Due to the low numbers and mixed bag of data, they could not make any recommendations from this. Retrospective reviews mostly look at anticoagulation alone versus anticoagulation with antiplatelet therapy. Anticoagulation with antiplatelet therapy in general seems to show better patency and lower rates of in-stent stenoses than with either one alone. And so what agent should we be using? The Swiss Venous Stent Registry looked at the anticoagulation after acute iliofemoral occlusion, therapy, and stent placement with a mean follow-up of 24 months. They used DOACs in about 2/3 of the cases and warfarin in the others. The rivaroxaban group had fewer mean days of anticoagulation, and they found no differences in patency, bleeding, or other complications. There are few studies to support any duration of anticoagulation other than those that need anticoagulation for other reasons. And I think a lot of us feel that the nival and post-thrombotic lesions should be treated differently. The AREVA study and the CTRAC study are both looking at anticoagulation and antiplatelet treatment after venous stenting, and hopefully these research efforts will give us a little more hard data as we move forward. So what do we do now? I think in talking to people, sort of like Dr. Black suggested, the common consensus that I have come up with is that for nival lesions, Plavix and aspirin for at least 6 weeks, maybe anticoagulation depending on the patient's history. If you have a patient who has had an acute thrombosis and a subsequent stent placement, at least 3 months of therapeutic anticoagulation is mandatory, and then probably antiplatelet therapy to follow. I personally do both anticoagulation and antiplatelet therapy from the get-go in this population. For those who have had a chronic thrombosis, if they aren't already being anticoagulated, generally anticoagulation and antiplatelet therapy for 3 months, and then make a decision after that with antiplatelet therapy lifelong. So in conclusion, nobody knows, but this is a great area of opportunity to expand our knowledge base around venous stenting. These are some general recommendations that I adhere to, and it seems in talking to people that these would be reasonable, but I would love to hear from the panel on what other people think is the most appropriate anticoagulation after venous stenting. Thank you.
Thank you very much, Dr. Dillavu. Needless to say, this is a burning problem because about 1/3 of the post-thrombotic patients may need reintervention for stent stenosis or obstruction. So I am sure that Dr. Hingorani is going to ask you the burning question on this. Dr. Hingorani is clinical professor of surgery and attending vascular surgeon at NYU Brooklyn Medical Center in Brooklyn, New York. Anil?
I wanted to point out that the way you broke up the three categories, I think, is actually crucial, not only for setting up how to treat these patients, but also how to categorize these patients. You broke them up to nivels, acute thrombosis, and those with chronic disease. And I want to actually ask you a question specifically because a lot of the literature sort of combines those three, and there's a lot of confusion which patients belong in which box. If you break them up into each one of those boxes, I think we actually end up with a better choice and better definition of what we're talking about, which we don't have right now in the literature. What patient-specific factors do you use for a nivel that you may decide to put on a DOAC, or combining a patient with acute thrombosis with the antiplatelet agent in addition to a DOAC?
Those are great questions, Anil. And personally, I tend to over rather than under treat with anticoagulation and antiplatelets. And I realize that I'm on that end of the spectrum, but a NIVL patient definitely gets antiplatelet therapy from me. And if they have had any sort of venous thrombosis in the past, even SVT, things like that, or if they have a family history of venous thrombosis, those are the ones that I will put on a DOAC for 4 to 6 weeks. I rarely do that. Mostly it's just antiplatelet. For the chronic component, I definitely lean heavily toward anticoagulation. They all get anticoagulated for at least 3 months in my hands, and I do antiplatelet therapy in everyone as well. And then for the acute stent placement, definitely both antiplatelet and anticoagulation for 3 months, and then sort of reassess, decide, what led to their thrombosis, how extensive was it, how much do they have left, et cetera, and make decisions based on that with a heavy hand on the anticoagulation.
Thank you very much. This was a great discussion and educational presentation as well. We'll move to the last presentation. The next distinguished speaker will be Dr. William Marston, President-elect of the American Venous Forum. Dr. Marston is the George Johnson Jr. Distinguished Professor at the University of North Carolina in Chapel Hill. The title of the presentation is Factors Affecting Outcome of Iliofemoral Venous Stenting. Welcome, Dr. Marston.
Thank you very much. It's really a tremendous pleasure to participate in this panel and honor Dr. Veith, as we all are doing. So I have no current conflicts in relation to this talk, but I was previously on the steering committee and a co-PI for the Vichy venous clinical trials. When we think about factors relating to outcomes, I think we have to separate out, because iliofemoral venous obstruction we know is heterogeneous. There are very different types of problems affecting the outflow tract. So a patient like I'm showing here that has a focal obstructive lesion at the confluence behaves very different from a patient like this with extensive post-thrombotic disease throughout the femoral and iliac system. And so I think, we really need to, there's quite a bit of effort going on, but we need to further this in starting to categorize patients. I think the discussion of nivels versus post-thrombotic is not very useful because someone may have had a clot in the past, but not really have very post-thrombotic looking veins and may behave more like what we would call a nibble. So really looking at anatomic extent of disease and severity of disease will be more important in the future to look at determinants of success. In general, a patient that has a focal obstructive lesion and not extensive post-thrombotic disease has a pretty good outcome with stenting. However, there are catastrophic complications that have been discussed that can happen in these cases if deployment of stenting is not performed correctly. But once performed correctly, they do quite well and have low restenosis or failure rates. Conversely, those that have long segment intrinsic obstructive disease are a completely different entity. They have a much higher risk of early stent thrombosis, need frequent re-interventions to achieve good long-term patency. So I'm going to focus my comments for the sake of the short time of this session to just those patients that have chronic obstructive post-thrombotic disease in multiple segments. And so a patient like this, a CEAP class 6 with large non-healing ulcer that hasn't done very well despite good compression and wound care in the clinic. When I think about things that are going to really allow us to open this patient's long segment obstruction, inflow from below is really at the forefront of my mind. I think if we can't get good inflow, it's going to be problematic. Then the technical aspects of crossing the occlusion, getting a lumen size that's acceptable. Boy, oftentimes I can't get up to 200 millimeters in the common iliac and I feel bad about it, but I do the best I can. And then good stenting of the entire length of venous segment and dealing with the venous confluence and some of those pesky filters that obstruct the IVC. This patient that I mentioned, this was his venous duplex, and you can see calcification in the chronically obstructed occluded femoral vein. That's a problem. Then I'm hoping that there's a good profunda that the flow is transferring through to give us good inflow. However, when we did access just below the knee, we couldn't see any outflow going up through this calcified femoral vein, and all you saw was little collaterals and no transformation into the deep femoral vein to give us outflow. So this is a case where you have to really give serious thought to not stenting this patient because it's going to fail if you don't have any inflow from below. Perhaps some hybrid approach might be useful, but you have to have judgment. And if you cannot establish inflow by opening these up with PTA or some other strategy, you're going to have stents that will re-occlude. So let's look at the literature and see what some of the studies say. So Dr. Black and his colleagues looked particularly just at occluded iliac veins and looked at their outcomes. So these are kind of the worst of the worst. Long segment obstruction from the common femoral up to the vena cava. And you can see their patency rate at 1 year was 59%. Lots of re-intervention is required. And Dr. Black spoke about you have to be very labor intensive with these patients. You see them frequently. I know he sees these patients 3 or 4 times in the first month after stenting them to see if they need any revision, any further stenting or redilating to try and keep these things from clotting. However, secondary patencies are quite good with labor-intensive follow-up and retreatment. One of the things they looked at was whether extension of the stents to the infrainguinal area affected patency, and there was no significant difference in the secondary patency if you had to go across the inguinal ligament. The key is getting to a point of good inflow. If you go past the inguinal, but even to the confluence, and you don't get to a femoral or a profunda that provides good inflow, then you're in trouble. Our group looks specifically at anticoagulation just in patients with chronic outflow occlusion. And so a different group, you have to look at these just in their own categories. This would not have any relation to someone who had a non-occluded iliac vein that probably doesn't need anticoagulation. So these were similar to Dr. Black's, about 2/3 we stented across the inguinal ligament, and we had almost a quarter of them re-occlude the stented segment within 3 months, despite pretty close follow-up. But with re-intervention, we got almost 80% of them secondary patency out to 4 years. When we looked at the risk factors for this early thrombosis, we found that if they had a known hypercoagulable state, it was more frequent. if they had more extensive occlusion, so if not just the external or the common, but if both were completely occluded, we had a higher rate of early thrombosis. And most interestingly, the type of anticoagulation was quite significant. So there were 11 different interventionalists who did these cases. We had cases from several different hospitals in our healthcare system. So there was quite a variety of anticoagulation and antiplatelet strategies. But the most frequent were the use of factor Xa inhibitors or the use of low molecular weight heparin for generally between 2 and 4 weeks. And we found that those that had low molecular weight heparin had significantly less incidence of early rethrombosis, only 5% compared to nearly 40% for those treated with factor Xa inhibitors. And this was the patency rate based on the type of anticoagulation, shows the same thing. So we certainly believe that in these chronic occlusions, you create more inflammation because you have to recanalize the tract and extensive stenting, the low molecular weight heparin for 3 or 4 weeks after, and then a total of at least 6 months of anticoagulation, which can be with the DOAC after the first 3 or 4 months, 3 or 4 weeks is the way to go. Evaluating the femoral inflow, we tried in this study, and there was a trend towards some significance, but it's difficult to actually categorize femoral vein inflow, so we couldn't get to significance of whether this was patent or not. And one other study by co-panelist here, Aaron Murphy, also looked at chronic total occlusions, 71 patients, and they were successful. And I brought this in to just say that even the best at the best of doing this aren't successful all the time, which you don't always hear on the podium. 15% of the time, they weren't able to reopen these chronically occluded veins. And that's, probably better than I do. Probably 75, 80%. Sometimes you just can't get through and get them reopened. But their follow-up was similar to the others that I've mentioned, with a significant number of early patency loss that you have to re-intervene, but with extensive work and re-intervention, you can get to high secondary patency rates. So in summary, I think we really need to look at the anatomic extent of disease and look at apples to apples when we're doing our studies and really classify these patients. Rethrombosis in those who have chronic occlusions is more extensive and more common if those that have hypercoagulable states and more extensive occlusion. And we like low molecular weight heparin, and inflow is critical. Thank you very much. Appreciate it.
Thank you, Dr. Marston, for the outstanding presentation. Now let me introduce the distinguished discussant for this talk. Will be Dr. Ravi Char, Professor of Surgery at the University of Pittsburgh Medical Center, Presbyterian in Pennsylvania. Welcome, Dr. Char.
Thank you very much for the introduction, Bill. I very much enjoyed your talk, very timely, and you've hit on multiple active issues with iliovenous stenting. As you have alluded to, and multiple speakers before you, the inflow continues to be one of the greatest challenges in treating iliovenous occlusive disease. How do you define optimal inflow, particularly when the femoral vein in the thigh is occluded? Is there a way to predict this beforehand? Are there any maybe duplex velocity criteria or volume criteria for the femoral vein or deep femoral vein that can help us predict a good outcome prior to embarking on an intervention? Thank you very much.
Thank you very much, Robbie. I think that is really the critical question here. And it's sort of the dirty secret. We all talk about it, but we don't really know how to quantify it. So some of it comes into a gestalt of looking at, particularly if the femoral vein is occluded, how good is the profunda? But there's not any duplex velocity criteria that I'm aware of that has been linked to predicting keeping that stent patent or preventing restenosis over time. So, and if anybody on the panel knows, please let us know, because I think that's a critical need in this area. It's one that needs more research, and we need to define it so we can translate this across to all others out there doing this type of work.
Thank you very much, Dr. Marston. We fortunately have some time for a discussion, and I would like to invite Professor Frank Veith, who our society honors, for his comments and questions. Dr. Veith.
Well, Peter, thank you. I'm so sorry. I had a little internet trouble and missed the first part of this. What really appeared to me to be a very excellent webinar. And I just thank and congratulate all the speakers. I think this is an area where technical excellence and ability make a huge difference. And I think that was brought out by Dr. Black's talk and Dr. Marston's talk. And Ellen, you certainly made contributions with regard to the anticoagulation, antiplatelet. I don't really have any learned comments or questions. I've enjoyed the part of this webinar that I've gotten to, and I apologize again for being a little tardy getting on. Thanks, Peter, and it's really been most enjoyable.
Thank you. Thank you very much, Frank. It's a real pleasure to have you with us. This has been really a great discussion of a very important topic, and appropriate patient selection came up multiple times, and we had a little debate between Professor Wittens and Dr. Jairaj, and I would like to come back first to that and give an opportunity to Case Wittens to answer the question of Dr. Jairaj and maybe tell us about the patient selection in the Netherlands.
Yes, well, thanks for getting this second opportunity. Okay, what Arjen was telling about the gradient, I am completely aware that that's not what I was talking about. That's a patient in a supine position with no flow in rest. The gradient will always be low and it's very difficult to find it. What we did is just puncture the femoral vein, measure the pressure in a patient walking on a treadmill and see what happens. And you see when there is an obstruction, the pressure significantly will raise. More than 20, 30 mils of mercury. We even have patients, young patients, 18 years of age, and they go up to 100 mils of mercury in the veins. So they get venous claudication because they get ischemia because the threshold between arterial and venous is getting too low. And that's a pressure measurement which I would really recommend before, because in our hands, and I know in the literature, certainly for nivels, we know that we have perfectly patent stents, but still with the patent stent, 30% at least will not benefit of the stent. So we did not select the right patients. And I think it's worth it to do this. It's an invasive measurement. It's a puncture in the femoral vein, but it's just a venous puncture, and measure the pressure when they walk on a treadmill. I think it's worth it to select those patients who do not need a stent. And that's the pressure measurement I was talking to. We did those pressure measurements in post-thrombotic syndromes with already known obstruction. So it's not that we do this routinely, but I'm having these discussions on appropriate care and the good patient selection. I'm more and more convinced that we should at least do a study that in everybody for a nivel, we do a pressure measurement and see if that will be a criterion in which you can say, well, this patient will benefit of a stent and that patient not. So I'm not talking about a pressure measurement in supine position in the patient on the OR. I'm really talking about the outpatient clinic measurement just before you indicate them for stenting.
Thank you very much, Case. Arjun, would you like to answer? I know you have done a lot of hemodynamic studies with or without exercise with Dr. Raju. Do you want to comment?
Yes, I read Dr. Wittens' paper some time ago, and it's an important point. We really haven't done treadmill testing in that setting, but then my question would be that is totally relevant in patients who actually present with venous claudication. But in our practice, an overwhelming majority of patients are actually C4 to C6. And so in these patients, with active or healed ulcers or severe hyperpigmentation and lipodermatosclerosis, would you subject them to a treadmill test? And if the treadmill test was negative, would you say that they're not going to benefit from a stent? And I think that's where the sort of, the reliability of hemodynamic testing, and we've looked at this up and down many times. is sort of still questionable, and that's why we don't, we're a little reluctant to, place everything on hemodynamic monitoring.
Thank you very much. We have several questions, and one of them is on CT venography. Maybe Dr. Murphy, do you want to comment whether you use CT venogram, and is it better than IVUS, or you use both?
Yeah, I use both. I feel that, there are people who ask me, why don't you just do IVUS and venogram on every patient? Well, that's not feasible if you're really seeing the number of patients that you do in a venous clinic. So I typically will work them up if I suspect obstruction with both a CTV and an iliac ultrasound. And the CTV, even if you don't have contrast, because let's be honest, most of them you don't, the non-con, you can still tell the caliber of the vein and the degree of compression under the artery, which I think winds up being better and correlating better with my IVUS at the time of the case than the ultrasound often does up at the top in the cranial section of the iliac. So I find that the CTs are extremely helpful in diagnosing which patients are going to improve. And frankly, in the NIVL patients, I don't stent those patients unless they have very significant stenosis or evidence of collaterals or longer disease lengths, things that really are hard to argue against.
Thank you very much. Dr. Black referred to the complications specifically on migration and fracture. And Steve, you wrote a beautiful review in the JVSVL about close to 60 patients who had stent migration. I think this is the most feared complication, that your stent will finish up in the right heart of the patient and cause sometimes fatal problems. So give us the sense, how can we avoid that?
Thanks, Peter. I mean, I think the first thing is what we've all been discussing is stent people who need a stent. So if somebody doesn't need a stent and they've got normal veins, the likelihood of a stent staying where you put it is much, much smaller, because the veins are compliant and can dilate up around whatever you put in, and that can move. So firstly, treat only patients who need treatment. The second bit of that is, if a patient does need treatment, I think what is clear to me is that small undersized stents are going to be a problem. So the concept of just stenting the compression point with a short stent of 60 millimeters or so is probably flawed. I think there's some people, Mark Meiser will argue for it, but you've got to have considerable experience to make sure you're getting it right. And I think probably in Mark's experience, he's treating people with virtual occlusions at the NIVL lesion with lots of fibrotic scar tissue that will hold the stent. And then in those cases, you could probably get away with it. But I think short stents will go and small diameter stents will go. This is not an argument for oversizing, because I think going too big is a problem in itself. It's about sizing it appropriately. And to me, it's about anchoring the stent in the external iliac vein around the bend in the pelvis. So you've got plenty of opposed wall between the stent and the vessel, and that's really important for NIVL patients. That's what's going to stop migration. In chronic post-thrombotic patients, you really don't see migration as an issue, because you're stenting a vessel that is, generally speaking, occluded, and the fibrotic scar tissue really grips those stents that don't move. So migration is a problem in NIVL patients, and unfortunately in NIVL patients is where our biggest problem is with over-treatment. So the two go hand in hand, and we've got to get both of those things right.
Thank you very much. Anybody from the panel has a question to one another? Please go ahead.
Peter,
Peter, I'm sorry, it's Frank Veith. I have a question to Dr. Wittens. When you do your venous pressure measurements with ambulation, you must put a catheter in. You don't do it just with a needle, do you?
No, indeed, we just put a Venflon in, just a small Venflon. You put it with a plaster, and that's it, and then they walk.
Oh, okay.
It's extremely easy. It's like an infusion in the arm. It's
right.
Exactly the same. But now I've got the mic anyway. I have a question related to the anticoagulation, to decide what the anticoagulation should be. I think we mentioned that patient characteristics are the reason to choose the anticoagulation, but I think in the near future also the geometry of the stent is very important. We are, for instance, now working on a new dedicated venous stent, which has a much higher porosity. And if you do animal studies, then in 4 weeks, the stent is completely covered. So it's out of the circulation, and anticoagulation is maybe not necessary. And as was already shown with the stents who are really straightening and the stent material is sticking out into the lumen, those are the reasons why you can keep them on anticoagulation, and which is crucial because then they will occlude. So I think stents who really nicely adjust to the wall and are flexible and have a high porosity, so which are in fact out of the circulation within 1, maybe 3 months in the future, that will influence anticoagulation significantly, despite, of course, the other reasons, because they have twice a DVT or whatever. But I think stent geometry, stent characteristics also influence the choice of using anticoagulation.
Thank you very much, Kees. Paul Gagné had a question. Enrico?
Yes, I have a quick question for Dr. Delavaux, which I enjoy very much your presentation. Dr. Delavaux, if one of our patient or your patient, 2 days after a stent placement for nivel, develops an intracerebral bleed, do you have enough literature to support the use of antiplatelet medication for venous stenting in that segment? Has anybody shown that this is a must?
Dr. Asher, thanks for your question. And I have to say, I really like your background, including the picture of Dr. Globitsky back there.
His new book.
Yeah, I know. But
Biography.
Good choices. No, I honestly don't think we've got great literature to support any choices, either, to anticoagulate or not, or antiplatelet or not, Lovenox versus DOACs versus warfarin. I know in some of the work Mark Garcia did, he found, as Dr. Marston did, that Lovenox is a much better early anticoagulant than either warfarin or the DOACs. So I think we've got a lot of learning to do, because obviously veins and arteries aren't the same. And just because we don't have dedicated venous research, we sort of fall into those arterial habits.
Absolutely. Thank you.
So one last question by Paul Gagné and then Enrico.
Yeah, Peter, I was just going to say, when we're looking at those nivel lesions, as Stephen mentioned, the rest of the vein is normal. And I think it's really important that dynamic imaging be done with the, and I find doing these with patients awake under sedation helpful, because sometimes we'll see some pretty significant size changes in the veins adjacent to the lesions, which means they're A, not stenosed, and B, if you're measuring to the smaller size, that stent's not going to be anchored. So I think dynamic imaging with IVUS is very important.
Thank you. Dr. Asher?
Yes, thank you. First, I want to congratulate you, Peter, for being a great president for the Frank J. Veith International Society. I mean, under your leadership, we have started this fantastic webinar with this great panel. I think this unique panel, actually, of experts, and like Frank would like to say, superstars in the area. And I also certainly would like to compliment Dr. Veith, who made this tremendous effort running in the hotel to come up to his room and join this webinar. We do organize those academic or educational programs, because we know that Frank's likes to do that better than going to a theater or to a movie or anything else. So I think that we have pleased him today with a great webinar. Thank you so much. I learned a lot. I made a lot of notes. It is a very exciting field, and I think we're going to hear from it many more about this subject. I also want to thank very much send my best to Alessandra Pugioni, who has started our program in Brooklyn of iliac vein stenting. I was a non-believer, but she convinced me, and we now have one of the largest centers for this. So thank you all, the speakers and the discussants and the moderators. And let's think about our next program, and let's participate on the activities of the Frank J. Veith International Society. Thank you all, and have a great afternoon and evening. Bye-bye.
Thank you.
Thank you.
Bye.
Be well.
Thank you.
you.